Hello, everyone. I'm excited to have this osteoporosis webinar. It's actually the second multidisciplinary osteoporosis webinar between University of Mansoura and University of Kentucky. Today, we are going to talk about the preventive and diagnostic challenges. And we have a multidisciplinary team between the endocrinologist, the nephrologist, the rheumatologist, geriatrics. So hopefully everyone will enjoy and learn from today's meeting. Today's meeting is 2 hours, and we have our honorary guest, Dr. Basil Masri. Is a consultant rheumatologist at Jordan Hospital. He's the director of Jordan Osteoporosis Center, and he is the founder and the president of the Jordanian Osteoporosis Society and the past president of the Arab League of Osteoporosis. We have moderators from the endocrinology, rheumatology, nephrology, geriatrics. We have Dr. Amani Musa, a professor of endocrinology in Mansoura University. We have Dr. Ihab Turabi, a professor of rheumatology at Mansoura. Dr. Ala Sabri, the chief of nephrology division in Mansoura. We have Dr. Said Hatata, the chief of geriatric medicine in Mansoura. Dr. Muhammad Yaqut, the chief of endocrinology division at Mansoura University. Today, we're going to start with quiz by Dr. Sally. Then we'll have our first lecture. We'll talk about diagnostic challenges. Dr. Hanan Abdelhai is going to discuss the osteoporosis diagnosis challenges. Then we'll have a case presentation and discussion. The presentation will be done by Dr. Heba Sobki. Then we'll have the second lecture, Dr. Mervat Isa. She is associate professor at Cairo University. She is a rheumatologist. She is going to talk about primary and secondary prevention of osteoporosis. Then the last case presentation will be done by Dr. Fatma Hamdi. Then that will be followed by discussion. Then we'll try to answer the quiz. I think I'm going to stop sharing right now and let to introduce her question.
Okay, hello everyone. Sorry to interrupt you, Dr. Am. So we have Dr. Basil Masri with us. His name is JSR. Can you please make him a co-host?
Go ahead, Sally.
Thanks, Dr. Amr. Good evening, everyone.
Good evening, everyone. It's our first time. This is about 55 years old woman with loose factors of osteoporosis. Your Lexus scan T-score number spine 0.8, femur neck minus 1.2. Which of the following statements is correct regarding this patient? A. This patient has normal bone density at the lumbar spine and osteopenia at the femur neck. B. This patient's bone mineral density test doesn't need to be repeated. Or C. There has been significant bone loss in this patient. D. This study showed an osteopenic patient with no risk factors for osteoporosis. E. The patient needs pharmacological therapy. Next question. What is the most appropriate advice regarding calcium and vitamin D for a 25-year-old female patient? A. 800 for calcium and 600 for vitamin D. B. 1000 milligram per day for calcium and 600 for vitamin D. C. 1200 for calcium and 600 for vitamin D. D. 1000 milligram per day for calcium and 800 for vitamin D. E. 1200 milligram per day for calcium and 800 per day for vitamin D. Next question. Which of the following tests is not useful in the evaluation of secondary causes of osteoporosis? A. For blood count. B. Corrected calcium. C. 25-hydroxy vitamin D. D. Spot urine calcium creatinine ratio. E. Thyroid function test. Next question. A 65-year-old postmenopausal woman with type 2 diabetes has a urinary fracture. She takes metformin 5-betazone. You decided to obtain TBS, which of the following statements is true? A. TBS requires additional images and radiation exposure. B. TBS can be used in combination with FRAX to stratify fracture risk. C. High TBS indicates poor bone architecture. D. TBS should be used to monitor response to bisphosphonates in diabetic patients. E. TBS can't be used to assess fractures. Question. 45 years old premenopausal woman with DEXA scan Z-score minus 1.8 at lumbar spine, minus 1.6 at head, minus 2.9 at the femur neck. Here's to our patient clinic with no history of fracture, smoking, drug intake, BMI 24 milligram, 24 kilogram per meter square, and has regular menses. Her vitamin D level is 22 nanogram per milli. Her dietary calcium intake around 750 milligram daily. In addition to optimizing calcium and vitamin D, the following statements would you recommend at this time? A. Reassurance and repeated DEXA scan in 1 to 2 years. B. Oral bisphosphonate therapy. C. Anabolic therapy. D. Regular weight-bearing exercise with moderate intensity. E. A combination of oral contraceptive containing at least 30 and 35 microgram smile estradiol. D was us.
So much. I think by the end of the meeting, we'll have answers. And I'm going to let Dr. Amani Musa to present our first speaker, Dr. Hanan Abdul Hai. Dr. Hanan Abdul Hai is a lecturer of endocrinology at Mansoura University, and she is going to talk about the diagnostic challenges in osteoporosis. Go ahead, please, Dr. Hanan.
Okay, thank you, Dr. Amr. Thank you for this elegant presentation, and I'll start now.
مش سامعين حضرتك يا دكتور حنان.
And Dr. Hanan, please share your screen after clicking on sharing the sound and the video. Otherwise, you need to talk live.
Okay.
We cannot hear the video, Dr. Hanan. Please talk live or share your
Is it
voice and your sound and
okay?
video.
So is it very not clear? Okay, so
No
I'll start
sound.
live.
There is no sound at all. Please talk.
Okay. So I am gonna talk now. Is it clear? The voice is clear now?
Yes, please go ahead.
Okay, so I'm gonna talk about osteoporosis diagnostic challenges today. These are my agenda for today. Osteoporosis is a challenging disease in diagnosis itself. It is not only the diagnosis, but the treatment, the choice of treatment, and the prevention of the disease is very challenging. So I'm gonna talk about osteoporosis. As you all know, osteoporosis is a progressive systemic skeletal disease which already can cause reduced bone mass and lead to a low traumatic fracture, which is known as a fragility fracture. The number of these fragility fracture is increased. We have about 1 on each 3 females and 1 on each 5 males is at risk for fragility fracture above the age of 50. The number of aging population is already increased in developed and developing countries. So we need to face the problem, or we need to raise the awareness towards this problem. So when I talk about osteoporosis, we have a lot of guidelines advocating the osteoporosis or the screening guidelines for osteoporosis. We have the American Colleague of Clinical Endocrinologists, the National Osteoporosis Foundation, the International Society of Clinical Densitometry. Thanks God, all of these guidelines have no differences between them, but I think only the National Osteoporosis Guideline Group, which is in UK, is the only one different in diagnosis. They recommend the use of Fractus score as a mean for screening for all postmenopausal female and men above 50 with a risk for fracture. So you can choose the best guideline you need, and you can start with this guideline as you need. So the road to diagnose osteoporosis full of hardships, a lot of hardships and hurdles along the road. We're gonna talk about them today, inshallah. At first, these are the most common diagnostic challenge we face: problem with the awareness, problem with the underdiagnosis even after occurrence of a fracture, problems with the imaging techniques and scanning process, problem with the fracture risk assessment tools, problem with missed folds assessment, and also what is the determinant of bone strength. Is it only the T-score is the only determinant of bone strength? I don't think so. Before we come to the diagnosis and the diagnostic challenge, we can talk about the common screening problems or pitfalls we're facing every day with our patients. Maybe the inadequate history, also the overlooking the symptomatology, problem with skipping the topic of exercise, problem with failure to ask about the medication or asking about different size and densitometry, or depending on the densitometry alone. I think it is a problem of perspective. The perspective of the physician subspecialty affecting him. So I think an endocrinologist can be focused on a postmenopausal female about the topic of screening for osteoporosis more than an orthopedic surgeon, for example. The first item in the diagnostic challenge is the patient awareness. Patient awareness remains as an unmet need for osteoporosis, which we are facing every day. So even with advocating a very easy screening techniques, we have a problem with the awareness. Even in developed countries, the people at target, less than third of them are screened. Up till now, how to best improve the patient awareness and communicate the fracture risk is not well established. So we have a problem with many faces and many problems, and we need more education. We just gonna list these problems or the faces of this problem. So the lack of screening, unwilling of treatment is one of them. Also, lack of access to particular treatment formulation and dosage are very divergent. The choice of the treatment itself is dependent on the physician and they differ greatly with each country. Attitude of a healthcare professional towards the education and so on also lack of simplified source of information. Our patient is in need for a simplified source of information. A simplified web page can list what is the osteoporosis, how can we manage osteoporosis, when to screen osteoporosis, and so on. The second item with the diagnostic challenge today is the underdiagnosis of osteoporosis, even with the occurrence of a fracture. As I told you before, National Osteoporosis Foundation recommended screening with a very simple and clear indication, also with using bone mineral density as a universal tool for screening. However, the rate of screening is very low, remain at 12 to 56% of the people at risk only screen. So the major reasons of this underdiagnosis, I can list them now. The underestimation of the seriousness of osteoporotic fracture. You need to know that the treatment of osteoporotic fracture is very highly expensive, more than the prevention of osteoporosis itself or the screening of osteoporosis. Also, the primary care physicians are overwhelmed with a lot of responsibility, so they have a little time to consider a silent disease and increase the risk of this event. Also, acute fracture is usually treated by orthopedic who are not responsible for long-term care and can't prevent further fracture. There is a lot of concern for our patient and fear related to the safety of bisphosphonate. These are the two first items. The third item is the scanning process or the imaging technique we are using to screen for osteoporosis. Do we have an imaging problem? Yes, we have an imaging problem. There is a problem with the DEXA scanning. There is a lot of problems with the DEXA scanning, like the scanner and its software itself, its technique and the proper calibration, a site acquired or required by the physician, patient positioning, and the patient positioning can cause various artifacts can be caused. Also, presence or need for a pre-DEXA scanning questionnaire, and this is very important. That it can indicate if we need bone densitometry alone or not, if we need also what is the follow-up interval between each of them, and what is the risk factor in this patient. This is the proper positioning of the bone densitometry scan. So if the patient is not improperly positioned, so we can have a false image or artifact in these DEXA scanning picture. So DEXA imaging not only measure the bone mineral density, but also vertebral fracture assessment and trabecular bone score, and we're gonna talk about them now. So osteoporosis bone mineral density follow-up is very important. The interval between each DEXA scanning is very important. You should know that the very high risk patient, not like the low risk patient, it can be from 6 months interval to 12 months interval up to 5 to 10 years interval. So the frequency of DEXA scanning also is a very common problem we are facing every day. Regarding the other techniques or the other measures of the DEXA scanning, we have the trabecular bone score. Trabecular bone score can reflect the gray level of the imaging of DEXA scanning itself, and it's very important. They found to be associated with a fracture risk in elderly women and diabetic patients independently of the bone mineral density. The clinical guidelines, especially the Spanish guideline, recommend the use of trabecular bone score in the assessment of fracture risk in subject with diabetes, and also subject on glucocorticoid therapy, subject with hypoparathyroidism and hyperparathyroidism, and the subject with osteoarthritis. But a drawback of the trabecular bone score, it can't improve the bone mineral density in assessment of the effect of treatment over time. So it can't be used as a follow-up of the effect of treatment itself. Also, the vertebral fracture assessment, one of the measures of the DEXA scan, it can measure by specific software. Vertebral fracture, why it is important? Because it is a predictor of all the types of fracture. Also, vertebral fracture are the most common type of fracture, about 2/3 of the fracture. Unfortunately, the vertebral fracture assessment can't assess the mild fracture but it is very important. So the International Society of Clinical Densitometry recommend the use of a vertebral fracture assessment for all women more than 70 years or men more than 80, for historical height loss more than 4 centimeters, for self-reported but undocumented barrier vertebral fracture, glucocorticoid therapy equivalent to more than 5 milligrams of prednisone or equivalent per day for more than 3 months. Regarding the other techniques or the other imaging techniques, we have a lot of other imaging techniques other than the DEXA scanning. It has a lot of pros and a lot of cons between them. So we have the DEXA scanning, we have also the quantitative CT and the MRI, which are more studied than the others. So we have as a pros for the DEXA scanning, DEXA scan can measure bone mineral density, vertebral fracture assessment, trabecular bone score, has a many validated studies. WHO recommended use of bone mineral density, National Osteoporosis Foundation, and a lot of guidelines. It can measure several sites and several applications. The quantitative CT have a very important pros which can assess the microarchitecture for the bone strength. Also, MRI can assess the microarchitecture of the bone, but it has also a drawbacks, like a quantitative CT has a higher radiation than a DEXA, less validated, also expensive. MRI is higher cost, low availability, poor precision, and also not available much in our facilities. Other diagnostic measure or other diagnostic technique is the bone turnover marker. Bone turnover marker can be used as the biological byproduct of bone remodeling that can change rapidly with the treatment, allowing an assessment of a treatment response in weeks to months. They found also increased urinary type 1 collagen CTX and the free DVD level were associated with twofold increase in hip fracture risk after adjusting for bone mineral density. Also, there is in a recent meta-analysis 70% decrease in bone turnover markers was associated with 40% lower fracture risk and with the use of bisphosphonate for 1 year. All these factors can help or suggest that the incorporation of bone turnover marker in the existing prognostic models could improve the predictor or prediction of absolute fracture risk. But we have also a drawback here or limitation for using bone turnover marker like pre-analytical and analytical variability, and the limited availability and affordability is one of the drawbacks here. The third or the fourth, I think the fourth item regarding the diagnostic challenge here is the risk assessment tool. We all know that we don't depend on mainly or only on the bone mineral density, but there is an algorithmic calculators. We use them, especially about 13.1 is present, but we have about 3 is more studied than the others, which are the fracture risk assessment tool, Garavan score, and the Q fracture have been studied extensively. Frax score is the one is worldwide used, as all of them are usually directed or advocated to older population. We can compare between them. This is the shape for the Frax score. We have no model for Egypt, but we use neighboring countries like Jordan. Okay. Regarding these tools and the effect between them, only Frax score is used internationally. Q fracture is used only in UK, but the Q score has a pro over these other calculators that it recommend or use a full risk, never neglect the full risk. Also, it doesn't neglect the CKD as a risk factor, CKD, chronic liver disease, also COPD, and the cancer and dementia, but it has a longer duration to complete this questionnaire. Garavan score is used in Canada, but can use worldwide. It is developed by Australian researcher, but unfortunately, it has a fewer data, lack of a lot of studies, so it is not dependable much. Regarding the Frax score, which is worldwide use, we have a limitation in the Frax score when we are talking about the Frax score, inability to identify imminent fracture, but no one of the other calculator also can identify imminent fracture risk. The dose and the time of exposure to glucocorticoid is neglected. The concurrent data on lumbar spine bone mineral density, the full risk and the full history is neglected. Also, we have a problem on reliance on the computer access. Not all countries have FRAX model. Missing CKD as a risk factor. Also, no controlled trials. Is age being like an ageist? Underestimation of risk in diabetic patient, also one of the drawbacks of FRAX. The fifth item or the fifth challenge here is the missed fall assessment risk. Do you all know that a simple question you can ask your patient about in the clinic is very important? Do you have an impaired balance? Do we ask our patients this question? Do you know that this simple question can prevent about 40% of a hip fracture? You should all know that the effect of aging is about 11-fold more than the effect of reduced bone mineral density. Also, they found that the fragility level or the fragility fracture increase in hip fracture rise about 44-fold in women from the age of 45 to age of 85. So a simple risk assessment tool or these assessment tools is very important and should be incorporated in all the algorithmic calculators of risk. So simple risk assessment like the 4-risk assessment tool, FRATAB, the Berg balance scale, and the full risk assessment score should be incorporated. As a conclusion for the problem with the missed falls and other factors, that we have there is a gap between the clinical knowledge in osteoporosis and the application in the practical life. I think we should all increase this missed fall assessment risk. Is very important. I think our colleague in geriatric unit are very familiar with using these skills. The sixth and the last item is the bone strength. Does dense bone mean strong bone? Does a long bone mean strong bone? This is not the right answer or the right questions. Bone strength itself doesn't depend only on the T-score or the dense bone. Any long bone can give dense bone, but this is not that doesn't mean this is a strong bone. There is a lot of factors that determine the strong bone or the strength of bone itself, like size and shape and the architecture of the bone and the bone composition itself. So these are the determinant of bone strength. There is no valued method to identify bone strength or not incorporated in any scale for assessment of the risk of a fracture. So differentiation between cortical and trabecular bone, matrix and the mineral deficiency in this patient and its effect on the bone health or strength, the shape of the bone, the size of the bone itself, and also very important factor is the biomechanics of the bone, which consists of the microarchitecture of the bone, and the accumulation of a recurrent microscopic damage is very important. But it's not at all, it is very neglected in risk. I came to end of my lecture and just I'm gonna talk about the take-home message or more than the unmet need or what I need more to improve the diagnosis of osteoporosis. We need to optimize the big bone mass acquisition in a young adult, optimize the diagnostic approach of the patient with clinical risk factor and for osteoporosis, also calculation of osteoporosis fracture risk. We need more good or more defined definition for a high risk patient, inclusion of an imminent risk fracture in the FRAX score, and also missed fall assessment risk, inclusion of bone strength as a measurable parameter. This was my reference and thank you.
شكرا دكتورة حنان. Thanks دكتورة حنان. في البداية أنا I would like to thank Dr. Amr, the main organizer of this meeting, and my colleagues Dr. Sayed Hatata, Dr. علاء, Dr. إيهاب, and Dr. أماني. في البداية أنا بس I would like to ask دكتورة حنان about you know the challenge for diagnosis of osteoporosis in many aspects. You know, every diagnostic test has a specificity and a sensitivity for diagnosis. What the most sensitive and the most a specific test for sure diagnosis of osteoporosis from the DEXA and the other tests for osteoporosis?
So thanks, Dr. Muhammad, for the questions, but I think it is not only one factor. There is no one factor can be determinant for screening for diagnosis of osteoporosis.
There is no
So-
gold standard for diagnosis
Oh,
of
I think
osteoporosis.
the calculators or the algorithmic or the fracture risk assessment tools is more than important than only scanning by trabecular bone score, vertebral fracture assessment, or only bone mineral density. One item alone is not sufficient. We need to incorporate all these items in a specific calculator or a specific algorithm to calculate the risk for osteoporosis, to prohibit or prevent the problem with the osteoporotic fractures. So one of them only is not sufficient to diagnose osteoporosis, or not the most specific one. I can't tell you that the bone mineral density is the most specific. Up till now, it is recommended as basal screening tool by a lot of guidelines, but it's alone has a lot of drawbacks. I think we talk about a lot of drawbacks, but it's alone can't be diagnostic one. I can't also depend on one of the other calculators. All of them has problems. So we need to incorporate, or when we are in need or in a dire need for a specific model for diagnosis of osteoporosis. So one of them is not sufficient. This is my opinion.
Okay. Another question. What about the trabecular bone score? You mentioned a lot of data about this model of diagnosis of our use of this trabecular bone score in some situation. Can you summarize when to use this trabecular bone score in situation معينة?
Yes. So trabecular bone score is the gray level texture measure extracted from the DEXA scanning image of the lumbar spine with a proper software already. It can be very important to also provide a picture or provide an idea about the bone microarchitecture as assessment for a fracture risk assessment independent of bone density. So it can be independent for bone mineral density, and it is recommended now to be used in corporation with the bone mineral density to enhance the predictive ability of a widely use of a fracture score. So it should be incorporated with bone mineral density in fracture score to give its best effort in this. Also, there is a recommendation to be used in diabetic patient, to be used in elderly patient with glucocorticoid, patient with hypo and hyperparathyroidism, and the patient with risk for osteoporosis having already osteoarthritis. These are the most common uses of trabecular bone score.
Okay. The last comment, Dr. Hanan, if there is a relation between severity of osteoporosis or osteopenia diagnosed by any models of these diagnostic tools and their choice of treatment. For example, in mild osteopenia, there is a choice line of treatment, specific line of treatment. And when there is severe osteopenia, there is another line of treatment. There is impact between, there is the relation between severity of osteopenia or osteoporosis and line of treatment to choose a line of treatment?
So Professor Muhammad, this is very important question. Does the number of bone mineral density affect our choice of the drug itself? I don't think this is the right thing we should be affected with, because the fracture risk itself is more important than the bone mineral density. Now, the treat to target is very important method for treating osteoporosis itself. But I think the choice of therapy should be based on the local management policies or the treatment recommendation, patient itself, patient state, patient age, comorbidity, concomitant medication, and the organ function. Say, for example, that specific types of bisphosphonate can't be used in CKD patient, also present of contraindication itself. So the choice of drug doesn't depend on the number of the bone mineral density of the very low bone mineral density. As I can tell you that the patient with moderate risk to osteoporosis can be treated by the same drugs can be used for high risk patients. So we can use bisphosphonate for both of them. But the choice of the drug doesn't depend on the bone mineral density alone. A lot of factors, especially the fracture risk of this patient, also is very important to start. And also, what is our treatment goal? Does we have a problem with the bone mineral density alone? Does we have a problem with this patient, the fracture risk assessment of the patient, the FRAX score of the patient, the bone turnover marker, which are increased? So according to our target, I think we choose the drug based on this target, not only the number or not related only to the bone mineral density.
Thank you, Dr. Hanan.
Thank you.
I think the talk with you, with Dr. Am.
Okay, thank you.
Thank you.
Thank you so much, Dr. Yahoud. Dr. Amani is going to present Dr. Heba Sharif.
Dr. Amani.
Okay, Dr. Heba Sharif Al-Saki is going to...
Aywa.
Yeah,
Yes.
go ahead, Dr. Amani, please.
Yes. Hello, everyone. Sorry, because I don't unmute myself. I would like to present the next speaker. I would like first to thank you, Dr. Amr, for hosting this meeting and the previous meeting as well. And welcome Dr. Basil Masri for joining us this meeting. I would like to present Dr. Heba Subki. She is the lecturer of internal medicine. Dr. Heba completed his residency in Mansoura University in specialized medical hospital in the internal medicine, endocrine, and the geriatric unit, and completed her master degree and MD degree in Ain Shams University, and now she is lecturer of geriatric medicine and gerontology. She will present us a case scenario. Please go ahead, Dr. Heba.
Case presentation. Female.
Yes.
Female patient, aged. Female patient, aged 67 years, housewife, married with 3 offspring, no history of smoking or other special habit of medical importance, no previous history of fall of fractures. Patient does no exercise and is fully mobile with no disability. Natural menopause at age 50. Patient hypertensive 5 years ago. There is no other comorbidity. No history of systemic glucosteroid use. Patient received diet rich in calcium, which about 1,200 milligrams per day, with from food only. Medications for this patient: Norvasc 5 milligrams per day, once daily, and multivitamin for all adults over 50. Family history: there is only positive family history of papillary thyroid carcinoma, no family history of osteoporosis, no parental history of hip fracture. Patient observed neck swelling in the left side of the neck, and the patient asked medical advice and was admitted at Mansour Oncology Center. On physical examination, height 160, weight 63.5 kg. Body mass index was calculated and it is about 24.8 kg. Blood pressure was normal range 136 above 84. Physical examination was unremarkable. The following investigations was done. Neck ultrasound was done and revealed presence of 2 small nodules in left thyroid lobe of mixed echogenicity with foci of microcalcification, and this was suspicious nodule, normal right lobe and isthmus, bilateral cervical lymph node. Laboratory investigation was done. CBC, thyroid function test, creatinine level, liver function test, bilirubin, albumin, and virology, and all laboratory investigations was normal. Echo was done, which revealed presence of ejection fraction about 68 to 9, normal left ventricle internal dimension with good systolic function, diastolic dysfunction grade 1, no resting segmental wall motion abnormality, no left ventricular masses or thrombi. There is normal left ventricular internal dimension with no visible thrombi, sclerotic mitral valve leaflet with mild mitral breakage, sclerotic aortic valve cusp with normal transvalvular flow, normal right ventricle dimension and right atrium with mild tricuspid regurgitation. Total thyroidectomy with central block neck dissection was done, and the pathological report revealed presence of multifocal papillary thyroid carcinoma focally infiltrating the capsule of the left thyroid lobe, right thyroid lobe, mild lymphocytic thyroiditis free from the tumor, reactive hyperplasia of two lymph nodes. Patient started thyroxine replacement and suppressive dose and the calcium supplementation, and the patient was discharged from Mansoura Oncology Center. But 4 days later, the patient developed hypocalcemic manifestation with generalized tetany, and the patient was admitted again at Mansoura Oncology Center. Laboratory investigation was done and revealed the presence of severe hypocalcemia. Serum calcium level was 7.4 milligram per deciliter. Serum magnesium 1.7 milligram. Patient received IV calcium with improvement, but after shifting to oral calcium, there was a marked drop in serum calcium, and the patient developed tetany again. Endocrinal consultation was done, and the patient was referred to our unit at specialized internal medicine hospital, and the re-evaluation was done. There was severe hypocalcemia, calcium level 6.7, serum magnesium 1.6, serum phosphorus high 7.6, TSH very high 43.7, and parathyroid hormone was low level 1.2, serum creatinine level was normal. Neck ultrasound showed presence of evidence of thyroidectomy with no residual or recurrence and few bilateral benign looking deep cervical lymph node, normal sonographic appearance of salivary gland. In this case, we have severe hypocalcemia, hyperphosphatemia, hypomagnesemia, and elevated TSH level. DEXA scan was done with total score at neck of the femur was -2.6, at the ward -1.6, intertrochanteric -1.6, and the total T-score at the neck of the femur was -2. T-score of the lumbar spine was -1.9, of the radius -3.7. Rax score was calculated for this patient with major osteoporotic risk 4.5. What is the primary diagnosis and treatment? Patient was diagnosed as having primary osteoporosis, but it is late in doing a DEXA scan, which is the main issue in screening of osteoporosis. So we have to screen for osteoporosis in the elderly. Patients have primary osteoporosis, but discovered on our department when screening for osteoporosis. And according to the guideline recommendation, patient was received tube with marked improvement in the serum calcium level and symptoms. As in our unit, when the patient received the IV calcium, there is improvement, but after shifting to oral calcium and 1-alpha, there is marked decrease. But after starting 4-2, the patient was improved with no return to hypocalcemic manifestation. Patient also received the thyroxine and suppressive dose, about 150, and there is improvement in the result of the lab. Serum calcium was normal, 9.4, serum magnesium was normal, 1.7, TSH returned to normal level, 1.7, and serum phosphorus was 3.6. And thank you.
Thank you so much. I just have a quick question. Did you consider using NetBara instead of Forteo for this patient, the whole BTH molecule instead of the 134 BTH?
in our the only available is 40 in our hospital.
Dr. Basil El-Masri, if you can hear me, can you please comment on the replacement for hypoparathyroidism? Can we use the Forteo, or do we need to use the whole BTH, the NetBara?
Assalamu alaikum jami'an. أولاً, thank you for the invitation. I'm honored to be with you. وتحياتي لكم جميعا من الأردن. Regarding this case, really there's many questions about the use of Forteo. Unfortunately, what we use, what we have available. There's no really comparison between the two products. In our area, in the Middle Eastern area, we don't have the 134, but we have only the Forteo, like you have in Egypt and in other Arab countries. But also we should consider the risk factors for this patient needing a bone former agent. From this case, it's clear and obvious there's improvement by using Forteo and after also receiving appropriate calcium and vitamin D. So I think since we have Forteo working properly, my question to Dr. Hiba, مظبوط, is not I'm mistaken. There's another DEXA scan comparing the previous one, the first one, or this is not yet done to compare the improvement, because bone former agent are rapidly improve BMD, bone mineral density.
This is the only available DEXA done in our hospital. No previous DEXA scanning.
After how long you are you stay, the patient stay in Forteo?
Patients stay in Forteo about 5 months, but no DEXA scan.
Okay.
5 months.
It's not enough. Do you have access to?
DEXA scan.
Okay. Are you repeat after 5 months DEXA scan?
No.
No, not yet. Yes, it's very short.
Short duration.
And what about the biochemical markers in this case for the bone former agent and bone resorption agents? Did you use them in this case to see the progression? Because in 3-4 months it's enough to see the improvement with bone biochemical markers.
We follow up only with serum calcium and phosphorus and magnesium. No other markers was done.
And kalam phosphatase, it was normal from the beginning?
From the beginning, it was normal.
Okay. It is an interesting case, but I think we need to, for this case, to see it again in the future after 1 year of Forteo of teriparatide to see if there's improvement. And we know that teriparatide should be followed by either bisphosphonate or anti-resorptive drug or denosumab to continue the improvement. We know that the recommendation to use bone former agent, then followed by anti-resorptive agents. Now with the new product, the romosozumab, it can combine both. Romosozumab, it's monoclonal antibodies used also for osteoporosis, high-risk osteoporosis, and it can include the action of romosozumab. It's bone former agent as well as anti-resorptive agent. But I think it's not yet available in all Arab countries. Even in Jordan, we don't have it yet. I don't know about Egypt if you have romosozumab.
We don't have it till now, Dr.
Yes, it's new. It's new. Thank you. It's a good case, and I'm happy also to congratulate Dr. Hanan with the really great presentation. Now I have my voice is hearing because I didn't have access before. So Dr. Hanan really has presented a very global presentation about osteoporosis, risk factors, and assessment.
Thank you, Dr.
Thank you so much, Dr. Basil. Now we are going to move to the second lecture. I'm going to present Dr. Mervat Isa. Dr. Mervat Isa is an associate professor in the rheumatology department at Cairo University. She did 6 months training with us at University of Kentucky. She is very knowledgeable and have very good experience of treating primary and secondary osteoporosis and to improve the bone health. Without further ado, she is going to talk today about the primary and secondary prevention of osteoporosis.
Dr. Amr, thanks all moderator, and it gives me pleasure to be here with you today in this multidisciplinary webinar. In the next 20 minutes, I will talk about osteoporosis in prevention. I have no disclosures. As you know, osteoporosis is one of the major global health problems. We know that we have at least 200 million people diagnosed with osteoporosis, and by 2040 this figure will be doubled because the world population is expected to increase from current 300 million individuals aged 65, and in the future in 2050 it will be 1.5 billion. So that means that a more and a more burden of this major global health problem of osteoporosis, causing a more morbidity and mortality with impact on the people function and the world economy. So the question now is osteoporosis, is this major global health problem, can be preventable or it is an inevitable condition? Before starting answering this question, we have first to have some definition. What is prevention? Prevention can be primary or secondary or tertiary. Primary prevention, mainly in general, it is protecting the healthy people against the disease. In osteoporosis, it means a prevention of reaching, helping is reaching the adolescent age with a normal and high big bone mass. For secondary prevention, in general, it means that screening people at high risk of the disease or with the disease or an early stage and treat them. Secondary prevention of osteoporosis mainly aims at reducing bone loss peri and postmenopausal and of course in older male. For tertiary prevention, it means rehabilitation patient with disease through medical treatment. Tertiary prevention of osteoporosis aims at preventing fracture and refracture. As we see here, after occurrence of the first fracture in the first 2 years, we have a marked increase in incidence of subsequent fracture from the first fracture. Osteoporosis can be classified into two types, primary osteoporosis and secondary osteoporosis. Primary osteoporosis, it accounts for more than 95% of cases of osteoporosis in women and in 70 to 80% in women. For secondary osteoporosis, it accounts for fewer than 5% of cases of osteoporosis in women, but a higher percent, up to 30%. And this is a list of secondary causes that leading to osteoporosis: endocrinal diseases, gastrointestinal, rheumatic, hematological, respiratory, metabolic, CKD, immobility, and a list of drugs that have an impact on the bone health. The major clinical risk factor for osteoporosis fracture in general, including age, mainly age, gender, previous fragility fracture, glucocorticoid therapy, history of falls, family history of hip fracture, and other causes of secondary osteoporosis I just mentioned, low body mass index, smoking, and high alcohol intake. On the other side, we have a protective factor for osteoporosis. It includes the includes greater height, greater weight, greater muscle strength, increasing in dietary calcium, greater physical activity, later age at menopause, and postmenopausal estrogen use. So let's start. How could we prevent osteoporosis primarily? Very important that we should know that we can help prevent osteoporosis by leading a bone healthy lifestyle at all stages of life, in all age groups, starting from childhood to adolescent to adult to old age. We can do an awareness campaign to increase the awareness of the community about the healthy lifestyle that ensuring a healthy bone in all stages and ages, as I said. But it is a little bit challenging because giving the patient advice about healthy lifestyle change can be hard. It is very easy for the patient to take pills, to do surgical procedure, but when it comes to lifestyle modification, it is so hard. So I think this is a very challenging point, and I think all physicians are dealing with osteoporosis should give concern to increase awareness to all population from all age group about the importance of leading a healthy lifestyle to ensure a healthy bone and preventing osteoporosis. This lifestyle risk factor leading negatively to impact negatively the bone mass density, and this occurs through two ways. Number one, inadequate development of what we call a big bone mass, or leading to an excessive rate of bone loss, or sometimes both ways. Another important factor, which is the genetic factors, which is very important, especially for what we call an attainment of the big bone mass among the family study, proving that the parent, offspring, and sibling correlation founding a correlation coefficient of 0.8 to 0.59. So what is the big bone mass, and what we care about this big bone mass? Actually, big bone mass achieving this big bone mass starting from early childhood, and 90% of this big bone mass is achieved in teenager, usually by age of 20. This is why I emphasize on the preventing measure we should take to prevent osteoporosis to start from early age, from childhood and adolescence. This big bone mass accounts for at least 60% of risk of all adult fractures and some diseases, and if it occurs in early life, in adolescent or childhood, and some medication interfere with this achieving normal big bone mass, leading to osteoporosis and fracture later on in the adulthood life. As we see here, achieving the big bone mass in women and men, and it reaching a plateau, and at the menopause, the rate of bone loss is women accelerated to be around 3% to 5% per year for 5 to 7 years before returning to the previous rate of decline. So how we could prevent osteoporosis? It mainly depends on 4 items. Number 1, increase awareness about the risk factor of osteoporosis. We should raise the awareness among population or among patients that they should know about the main risk factor of osteoporosis. This is very important. Number 2, advise about the secondary causes of osteoporosis, controlling this causes leading to osteoporosis, like medication, glucocorticoid, reduced mobility, endocrine disease, hypogonadism, compromised nutrition, and inflammatory cytokines in autoimmune disease. Number 3 is the calcium and vitamin D supplementation, and number 4 is the physical activity. So let's start number one with lifestyle modification, which is exercise. It is very important because we know that the high mechanical load experienced during exercise lead to an increase in the bone density, particularly during childhood. A study in childhood proved that a short-term exercise program 3 times a week resulting in a significant bone mass density. And for the adult, we should keep active, take regular weight bearing, and muscle strengthening exercise is very important for our bone health. It's okay, of course, to lose weight to the ideal body weight and lose fat, but it is not okay to being too thin or losing weight so that you reach body mass index less than 18 or 19, because this low bone mass index is one of the risk factors leading to osteoporosis, and it is very damaging to our bone health. Important factor to prevent osteoporosis in all age groups, that ensuring a healthy diet, which is important to our bone. The major two key nutrients for our bone health are calcium and protein. Of course, in the diary, and some nutrients like fish, eggs, mushroom, fortified dairy food, and juices. This is very important to ensure a healthy diet for all age group. And as I said, the most important is calcium, and of course vitamin D. This should be given supplementation to all of calcium and vitamin D to all age group, and the dose of calcium and vitamin D is different according to the age group, as summarized in this table. And if the patient have a vitamin D deficiency in any age group, we should correct this or treat this vitamin deficiency according to age with vitamin D 2 or 3, 50,000 international unit weekly for 8 weeks in children, or 3 months in adult, followed by a maintenance dose according to age. Another important measure for preventing osteoporosis, for primary prevention on osteoporosis, which is stopping smoking. Smoking is directly toxic to our bone cell. So current smoking have an increased risk for hip fracture. So it is very important to advise your patients to stop smoking immediately. For alcohol, it is very important to know that excessive alcohol consumption leading to a negative effect of the bone mass density. So you should advise your patient to take 3 or more drink equivalent, take an average or amount of alcohol, or even stopping drinking alcohol for its not just on the bone, but also it is linked to the consciousness and leading to the patient is more risky to falls, and this is leading to increased risk of fracture. For caffeine, excessive caffeine has been associated with decreased intestinal calcium absorption, so it is advised to take an average amount of caffeine consumption. For secondary prevention of osteoporosis, CELAR have set some recommendations for management of patients older than 50 years with fragility fracture and prevention of subsequent fracture. It includes the multidisciplinary management from different specialty of the patient, and assessment of the risk factor in patient aged 50 years or more, evaluation of this risk factor, and appropriate and non-pharmacological and pharmacological treatment of patients who showed risk for subsequent fracture. Start first with how we stratify the patient according to their fracture risk. Using this tool, RefRax is an important web-based tool in assessment of fragility fracture. And the patient who we should assess for fracture risk, patients or women aged 65 or more, or men aged 75 or more, and women younger than 65 and men younger than 75, but they have risk factors. Indication to use medication, pharmacological treatment to prevent subsequent fracture, including hip or spine fracture, bone mineral density, bone mass density, T-score less than or equal to -2.5, bone mass density between -1 and -2.5, and +1 of the following, either 10 years risk of major fracture of more than or equal 20%, or 10 years risk of hip fracture of equal or more than 3%. And the pharmacological treatment or line of treatment used to prevent or secondary prevention of osteoporosis, including the estrogen agonist antagonist, the bisphosphonates, which is usually used as first line in treating osteoporosis, and as you see here, all pivotal trial showing that there is at least 40% reduction in the fracture. And for denosumab, the FREEDOM trial showed that patients who were on denosumab showing 40% reduction in hip fracture and 20% reduction in non-vertebral fracture. For teriparatide in men with osteoporosis randomized control study, they showed that the relative risk of new fracture was just 0.5. And the newly FDA immunized monoclonal antibody sclerostin inhibitor romosozumab, which used in postmenopausal osteoporosis, women with high risk of fracture, including osteoporotic fracture, multiple risk factors, or failed to intolerant to other available osteoporosis therapy. One of the most important measures in secondary prevention of osteoporosis fracture in old age is the prevention of falls. We know that there is a lot of causes, especially with aging in old age, leading to fall, neurological disease, cerebrovascular disease, medications that cause affecting the consciousness or leading to imbalance, the musculoskeletal condition, arthritis or osteoarthritis, all these factors leading to repeated falls, and this is maybe very risky to get the patient to get a fracture, a major fracture, hip fracture. So we should predict this fall and we should prevent them. Among causes of secondary osteoporosis was the rheumatic disease or autoimmune disease. This could be preventable, so I'd like to stop here and explain why this is preventable. We know that the autoimmune rheumatic disease per se leading to osteoporosis. This is called osteoimmunogenesis. The cytokines released in the inflammatory response in these rheumatic diseases like interleukin 1, interleukin 16, and F-alpha, leading to a negative impact on osteoblast and a positive activating the osteoclast, leading to less bone formation and more bone resorption. This is leading to a negative bone imbalance and leading eventually to osteoporosis. This can be prevented. How? By good control of activity of inflammatory rheumatic diseases like rheumatoid, lupus, and all other inflammatory rheumatic diseases. Controlling the activity with a proper treatment is a very important step to be taken to prevent osteoporosis in those patients. Another cause that leading to secondary osteoporosis and preventable is the glucocorticoid-induced osteoporosis. As you see here, it is the X-ray lateral view of spine of a patient on oral steroid for long duration. You can see the multiple wedging. This is catastrophic. This is one of the major adverse events of steroids. So we should, to prevent glucocorticoid-induced osteoporosis, we should prescribe steroid by the needed doses for a proper duration, and please taper steroid as early as possible. As it is clinically visible, please taper the steroid and don't let your patient for unneeded duration, unneeded higher doses of steroid. How steroid leads to osteoporosis in patients receiving glucocorticoids? We know that they have negative impact on bone formation and activate and positive on bone resorption, affecting the trabecular bone, so that we see in most of cases wedging fracture in the spine, vertebral fracture mainly, affecting only the bone stem cells and leading to decreasing differentiation to osteoblast, disrupt the osteocyte canalicular network and reducing the synthesis of type 1 collagen and osteocalcine, and also steroid leading to decreased absorption of calcium from intestine. All these factors leading to osteoporosis. Of course, the longer the duration, the higher the dose, the higher risk of osteoporosis. So the American College of Rheumatology put some guideline for prevention and treatment of osteoporosis in 2017 and its update in 2022. As we can see here, they are classifying the patient according to the dose and duration of steroid, and then classifying according to age, childhood or in adulthood, less than 40, more than 40. In all age group receiving steroid, we should ensure vitamin D, calcium, and lifestyle modification, and according to risk, we are adding the pharmacological treatment according to the risk of fracture. We can use the anti-resorptive like bisphosphonate, denosumab, or the bone-forming agent like teriparatide and romosozumab. And here, as we see, we are starting to prevent osteoporosis. We are starting with initial fracture risk assessment in all age group, and according to this risk assessment, we should do DEXA or not. And every year we should do a reassessment of fracture risk, and according to the fracture risk, either mild, moderate, high, or very high, we should treat. Secondly, prevent osteoporosis. And thank you very much.
Thank you, Dr. Mirvet, for your illustrative talk. And Nital, we receive a question from the chat box. I have one question for you, please. Do you recommend doing during screening for high-risk patient to depend on ultrasound done on the heel as a portable and easy method, but not recommended in the guidelines? Do you have experience in using it during screening? Dr. Mirvet, you hear me?
It seems she has an unstable internet.
Well, I
There is
asked
a
her
question
to
in the chat box. I think it's for you, Dr. Amr. Why diabetic CKD patients are more prone to a dynamic bone disease? We can answer it together.
Okay. Yes. So, especially in CKD patient, is associated with decreased rate of bone formation. It's multifactorial because diabetics are usually overweight or obese. They have metabolic syndrome. CKD is part of the metabolic syndrome. They tend to have lower BTH levels, and also there is some resistance of the BTH at the bone level and at the receptors levels. So it's multifactorial. Also, in patients on dialysis with advanced CKD, the majority of peritoneal dialysis patients are diabetic, and peritoneal dialysis patients, they are at a high dialysate calcium bath. So if you increase the calcium in the dialysate, probably you can induce a dynamic bone disease because you over suppress the parathyroid gland. Again, it's multifactorial, but this observation is correct. And the questions comes in, do we really need to treat diabetics with osteoporosis as non-diabetics if they have higher chance of low turnover bone disease? Can we use osteoanabolics rather than the anti-resorbatives? Can we use BTH or BTHRB or romosozumab instead of bisphosphonates and instead of the rank L monoclonal antibodies? I think it's a big question. We need to see, randomized clinical studies comparing both anti-resorbatives and anabolic therapy, osteoanabolics, in diabetic patients. But I really recommend that if you're going to use the anti-resorbative therapies, you need to follow the response. Don't forget that these agents can induce more low turnover bone disease and adynamic bone disease. So if you are not sure, try to use either non-invasive bone turnover biomarkers to make sure that the patient doesn't have low bone formation and you're going to over-suppress the bone formation. Sometimes actually we need to do bone biopsy in a small percentage of patients to see exactly the TMV, the turnover mineralization, and the bone volume by the bone histomorphometry to guide the therapy. But that's
Thank you, Dr. Amr. As regarding monitoring the bone turnover in the patient to detect the low bone turnover bone disease, when we ask for doing the bone biomarkers, the usual impressions that they are not available and very costly. But could we depend on the available ones like measuring the BTH and alkaline phosphatase, either total or bone specific, especially if they are markedly decreased and increased?
Of course, yeah, that's another good question. Very low and very high BTH and alkaline phosphatase level are very helpful. So in our dialysis patient, our target is to keep the BTH between 2 to 9 folds of the upper limit of normal. So we try to keep the BTH between 150 to 400 or 500 because BTH less than 150 is associated with low turnover bone disease. BTH over 5 or 600 is associated with high turnover bone disease in our dialysis patients. So bottom line is, if you have very low or very high BTH, it correlates very well with the bone turnover. But the problem is the majority of our patients are within this target of 150 to 400 or 500. If the BTH is in this target, it's very hard to tell if the patient has low or high bone turnover. Again, using total alkaline phosphatase and bone-specific alkaline phosphatase would help. But yeah, in patients with borderline numbers of the alkaline phosphatase and BTH, we encourage to use TRAB5B, which is a bone resorption marker to see if the bone resorption is high. So we treat the patient with anti-resorbatives if it is low, with low alkaline phosphatase, which is that alkaline phosphatase is a bone formation marker. So this will help us to guide the therapy. Thank you for the
Yes,
question.
thank you. Okay, we have still time for discussion, or we stop
I think
here?
we have 2 minutes.
Yes, I would have a question for Dr. Mirvat, who is still with us. She's not with us.
Dr.
Dr. Amani, do you hear me?
Yes. Dr. Mirvat?
Yes, Dr. Amani. I just unmuted myself. Okay.
Yes, thank
Please
you.
repeat the question.
You heard my question, my previous question?
No, just please repeat it.
Yes. Do you have experience or do you recommend using ultrasound during screening for osteoporosis among high-risk patients?
Thanks, Dr. Amani, for
As a portable
yes.
and non-expensive.
Yes. Yes, this is very important question. Good question. Thank you. I think DEXA will be the golden method for screening and diagnosis osteoporosis. Of course, another methods include ultrasound. It has advantages, as you said. It can be portable, can be easy, non-invasive, with no exposure to radiological يعني ما فيش زي في حالات السي تي. But I think ultrasound is not an accurate method for diagnosis or screening osteoporosis.
And not put in the guidelines.
Yes, it is very recent and it is still not in any guidelines. That's correct.
By using DEXA, you recommend doing on the 3 sites? It's essential to do the 3 sites for each patient?
I think Dr. Basil can answer this question. Go ahead, please, Dr. Basil.
About ultrasound, I think, yes.
About ultrasound and use
Yes.
of 3 sites for DEXA scan.
Yeah. About ultrasound, we have the experience in Jordan because we use it as screening machine when we founding the Jordanian Society for Osteoporosis. And it helps just to send patient to DEXA scan. Not more than that. I agree with Dr. Mirvat about the comment. So it's not really a practical tool for assessment of osteoporosis, just can help in remote areas because we don't have DEXA scan everywhere, as you know. Especially we have this in big cities and just only a few centers. So this regarding using many sites, I personally prefer use many sites. It helps. The routine, what I do now in DEXA scan for all patients have both hips, lumbar spine. For now, we know it's helpful for hyperpara, but TBS including and FRAX including in the now new machines we can have FRAX and adjusted FRAX to TBS can help a lot, either positively, which means sometimes we have a T-score minus 2.6 and with TBS high normal TBS, which will adjust it to minus 1.9, by example. I have many examples like that. Or the opposite, in diabetes patients or glucocorticoid patients, we can have TBS very degraded and it can also switch T-score from minus 2, as example, yes, minus 1.9 to minus 3, sometimes minus 4. And it helps for the therapeutic decision. So I think now I agree with all the distinguished previous speakers that we should use all the tools to assess risk factor for fragility, fracture, not for osteoporosis as definition in the WHO, because it's now it's obsolete. It's not really practical to use this guidelines created in 1995, and now with many tools, clinical risk factors, as clinician, we should use it. In addition to the other tools we have, the TBS, including the FRAX, also very important. And also we need to also fix the therapeutic threshold for each country, for each population. I think in the Arab countries there's a similarity, but it is a big discussion about FRAX and the difference FRAX in between Arab countries. So I agree to use many tools and many sites to fine-tune the diagnosis and really prescribe the adequate treatment. Because also we should not forget there is over-diagnosis, especially in premenopausal women. there is a lot of overdiagnosis and unuseful and treatment.
Thank you so much, Dr. Basil. And I want to add, if you permit me, that screening the three sites are also important because there is differential effect on the hormones on the different types of bone. For example, post-menopausal osteoporosis mainly affect the alveolar bone present in the trabecular bone present in the spine, while diseases then like parathyroid diseases, hyperparathyroidism affect mainly the cortical bone present in the periphery. So doing the screening on the three sites is very important as well. Thank you so much, and I will leave the talk to Dr. Ihab to introduce the next.
Thank you very much. Thank you very much, Dr. Amani. It's my pleasure to introduce one of the eminent eminent member of our rheumatology unit. Dr. Fatma Hamdi will talk about avoidable loss, a very hot topic about the use of steroid therapy and problems of steroid therapy and how to avoid the osteoporosis induced by glucocorticoids. Please, Dr. Fatma, go ahead.
Bismillah ar-Rahman ar-Rahim. First of all, I'd like to express my happiness for participation in this meeting. During the management of autoimmune rheumatic diseases, we are using multiple medications with many adverse effects. Do you think that we can avoid the loss? We will answer this question in our case presentation, inshallah. Case number 1, it's for a female patient, aged 40 years, from Mansoura, housewife with 2 offsprings. The youngest is 12 years old with no special habits of medical importance. Patient has regular menstruation recurring every month with average amount and duration, with history of 1 abortion in the 2nd trimester. Patient has a long history with systemic lupus. She is known to be SLE for 15 years. She developed cerebral vasculitis 15 years ago, for which the patient received solmidrol pulse, 6 grams of cyclophosphamide and hydroxychloroquine. 12 years ago, the patient developed lupus nephritis, for which the patient received solmidrol pulse, MMF, and hydroxychloroquine. And 7 years ago, the patient developed thrombocytopenia, for which the patient received high-dose steroid, cyclosporin, and hydroxychloroquine. And currently, the patient is taking prednisolone 5 milligrams per day, calcium, vitamin D, hydroxychloroquine, azathioprine, and proton pump inhibitors. During her routine follow-up, the patient came to our clinic with low back pain, which was gradual in onset and progressive in course for 1 month. Patient has no history of trauma or fever. Musculoskeletal examination revealed tender lumbar spine on palpation with limitation in spinal movement. Normal examination of all other joints. There was no edema lower limb, no abnormal skin rash or oral ulcers. X-ray lumbosacral spine was ordered, and unfortunately, it revealed lumbar vertebral widget compression fracture. So we asked for a DEXA scan, and it revealed severe osteoporosis. T-score was -4.3 at the femur neck, and it was -4.2 at the spine. Now we have a question about this case. How to avoid osteoporosis in autoimmune rheumatic diseases, when to do the DEXA scan, what about the steroid dose, and what's the role of bisphosphonates as a prophylaxis. As regard case number 2, which is for a female patient aged 37 years from Mansoura, housewife, married with 3 offsprings. The youngest is 10 years old with no special habits of medical importance. Patient has regular menstruation recurring every month with average amount and duration. No history of pregnancy loss. She is using IUD as a contraception. As regards systemic lupus history, she is known to be SLE for 10 years. her condition started with musculoskeletal symptoms and skin rash, for which the patient received prednisolone 20 milligram and hydroxychloroquine. Patient also then developed thrombocytopenia, for which the patient received prednisolone 30 milligram, hydroxychloroquine, and azathioprine. Currently, the patient is taking prednisolone 10 milligram per day, hydroxychloroquine, azathioprine, and proton pump inhibitors. However, unfortunately, our patient was not compliant on calcium and vitamin D supplementation. Also, during her routine follow-up, she mentioned that she developed tibial fracture on minimal trauma, and there was no other symptoms or signs suggestive of active systemic lupus, for which we ordered DEXA scan, and the T-score at the distal radius for the patient was minus 3.4, and it was minus 2.7 at the lumbar spine, for which the patient was diagnosed as having osteoporosis. We encouraged the patient to take calcium and vitamin D. We encouraged her also to have lifestyle modification, and we gave the patient anti-resorptive drug denosumab. 6 months later, the patient had unplanned pregnancy. She came to our clinic, worried about pregnancy and lupus activity, the management of osteoporosis during pregnancy, and effect of pregnancy on her bone health. As regards lupus activity, we evaluated lupus activity clinically, and also we ordered investigations, CBC, urinalysis, ESR, serum creatinine, anti-double-strand DNA, antiphospholipid antibodies, anti-Rho, anti-La. All these investigations were normal, and as regards the clinical evaluation and lab investigations, we are in front of a case of quiescent lupus. So now the question for this case, what's the effect of pregnancy and lactation on bone health? And how can we prevent osteoporotic fractures during pregnancy and lactation? And now it's time for discussion.
Thank you very much, Dr. Fatma. If anyone have question to Dr. Fatma, I would like to ask you, Fatma, how to minimize the risk of steroid-induced osteoporosis. What's your experience and what guidelines say to us?
I think Dr. Merva talked about this in her lecture. As regard the practice, we should do a fracture risk assessment for patient receiving steroids. Also, according to the fracture risk, according to the age of the patient, we should do screening with DEXA scan for the diagnosis of osteoporosis before occurring of fractures. Also, it's very important. The dose of steroid the patient is taking is very important. It's very important to minimize the dose and the duration of steroid intake. And it may be slightly difficult in patients with systemic lupus because there is recurrent disease activity. They may require long-term maintenance on steroid therapy. However, the current guidelines is to use the pulse therapy for management of flares and also management of refractory disease, which allow us to start with a minimal dose of steroids and allow more rapid withdrawal of the steroid. As all we know that the deleterious effect of steroid either in bone or muscle or other side effects is related to the genomic effect, which is usually related to the long-term intake of steroids. However, the pulse therapy is less deleterious on bone. And also the other measures, as Dr. Mervat said, the lifestyle modification, the calcium, the vitamin D intake, and also according to the risk of fracture, our patients can receive the oral bisphosphonates as a prophylaxis.
Thank you so much, Dr. Fatma. Very, very nice, interesting cases. I just have a very quick question for you. Back to the ultrasound and assessment of bone health. I know that somebody asked this question in the past. Is there any rule during pregnancy? Because it's probably you're not going to do any DEXA scan during pregnancy. That's number one. Number two, what about steroid-sparing therapies? Now we have voclosporin, we have belatacept. Of course, Black O'Neill, 200 milligram twice a day would also help to, spare steroid, good dose of MMF or even cyclophosphamide. I don't usually like cyclophosphamide and, early on, especially in ladies. But anyway, because I think there is a trend to use a lot of steroids instead of steroid-sparing therapies in Egypt. Do you agree with me? You are muted, Dr. Fatma.
The question is for me?
Yes, I have two questions. First, is the use of ultrasound during pregnancy to evaluate the bone health. Second, use of steroid-sparing therapies instead of giving a lot of steroid and inducing glucose.
Okay, as regard using ultrasound for evaluation of osteoporosis during pregnancy, I think ultrasound is safe and can be used during pregnancy, but I have no much experience about using ultrasound in evaluation of osteoporosis. So I'm sorry, I cannot answer this question. I have no experience about this. As regard the
I think
steroids,
ultrasound, Dr. Fatma, I think
steroid for
ultrasound
assessment of
Dr. Fatma, I think ultrasound is important and can clarify signs of inflammation, fluids, and so on. But I think still DEXA is more accurate for osteoporosis diagnosis than ultrasound, Dr. Amr. Go ahead, Dr. Fatma.
as regard the steroid-sparing agents, it's very important. And now the new guidelines is to try to use effective steroid-sparing agent. And if the patient having flare or uncontrolled disease, try to change the immune suppressive or steroid-sparing agent. This will help you to withdraw the steroids, and you can change the immune suppression according to the or the steroid sparing agent according to the presentation, the clinical presentation of the patient, instead of increasing the dose of steroids. And also, as I mentioned before, the pulse therapy, the use of pulse therapy in case of flares or refractory disease can be tried. It also increases the effectiveness of the subsequent steroid doses and increase our ability to withdraw the steroids. And now currently we have a lot of new steroid sparing agents that can be used and will help us to minimize the cumulative dose of steroids used in patients with SLE.
And can you use voclosporin or belatacept during pregnancy or not? Do you know?
I don't know. We are using cyclosporin during pregnancy, but I don't know what about the voclosporin.
We don't have them till now, Professor
Yes.
in Egypt.
We are using the cyclosporin safely.
I think they are like new agents, so I don't think that there are data about using them in pregnancy. But you see now in pregnancy, I think.
Yes, yes, we are using
so my question is there a specific effect of mycophenolate mofetil or cyclosporin on bone, a direct effect?
I think, Dr. Muhammad, their effect on blood pressure, gastrointestinal, rather than osteoporotic events. We are use them usually with steroid, even minimal dose of steroid. We encounter the incidence of osteoporotic fracture, avascular head more with the steroid. I don't know they have effect on the bone. Dr. Fatma.
Dr. Basil Masri wanted to add something.
Yes, please. I see that in both patients, they are using PPI, and we know chronic use of PPI also it's a risk for fragility fracture. So do you use regularly and for long-term PPI in your patients or just for a short period during using NSAIDs or corticosteroid?
Unfortunately, you are using PPI with steroids. We are prescribing steroids with PPI for all patients. Yes. Do you think
So
we should not do
we should
this?
consider as a risk factor for osteoporosis, for fragility fracture. Yeah.
Yes.
We have also, in addition to corticosteroid, in addition to the disease activity as inflammatory or autoimmune disease is a risk factor for osteoporosis, we have another risk factor, the chronic use of PPI.
The patient number 2, our patient was not taking calcium for GIT upset. Most of patients having GIT upset when they are taking steroids and calcium. I think nearly all patients we are giving all patients PPI with the steroids and calcium.
Thank you.
Not just the GIT upset, but they are prone to gastric ulceration.
Yes, yes, you are right.
Yes, for second time, thank you very much, Dr. Fatma. We move to the next speaker.
Thank you so much, Professor Ihab. Thanks, Dr. Fatma, for the excellent presentation. The last part, I'm very happy that we are very good with time. The last part of our webinar today is Dr. Sally Samh is going to give us the rationale and explanation of the correct answer for her quizzes. Go ahead, please, Sally.
Thank you, Dr. Ram. Ready to answer our quiz? My first.
We cannot hear if you have recorded video, you didn't share the voice.
Okay, my first question, 45 years old woman with no risk factors for osteoporosis. Her DEXA scan T-score lumbar spine 0.8, femur neck -1.2. Which of the following statements is correct regarding these patients? Actually, osteoporosis is a systemic disease. We can, one site affected, confirm the diagnosis. So the most suitable answer is D. This screening study showed an osteopenic patient with no risk factors for osteoporosis. Next question, what is the most appropriate dietary advice regarding calcium and vitamin D for a 75 years old female patient? Female patient more than 70 years old in need of calcium more than 1,200 milligrams per day and 800 per day for vitamin D. So E is the most suitable answer. Which of the following tests isn't useful in the evaluation of secondary causes of osteoporosis? We are in need of corrected calcium, vitamin D, urine calcium creatinine ratio, thyroid function test. So A is the most suitable answer. A 65 years old postmenopausal woman with type 2 diabetes has a humeral fracture. She takes metformin, bioglitazone, decided to obtain TBS. Which of the following statements is true? As Dr. Hanan mentioned, the TBS, no need for additional images, no need for radiation exposure, can be used in combination with FRAX to stratify fracture risk. High TBS indicate a good bone architecture and can't be used to monitor the response to bisphosphonates in diabetic patients. So B is the most suitable answer. It can be used with combination with FRAX to stratify fracture risk. A 40 years old healthy premenopausal woman with DEXA scan Z-score -1.8 at lumbar spine, -1.6 at the hip, -2.9 at the femur neck, referred to our patient clinic. No history of fracture, no smoking, drug intake, BMI 24 kilogram per meter square, regular menses, her vitamin D level 22 nanogram per milli, dietary calcium intake around 750 of elemental calcium D, In addition to optimizing calcium and vitamin D, which of the following would you recommend at this time? Our patient is healthy, no risk factors of osteoporosis, no history of fracture. Regular weight-bearing exercise of moderate intensity will give her a great beneficial effect and increase bone mineral density. So D is the most suitable answer here. And thank you all for listening today. Thanks to our moderators.
Thank you so much for this intellectual, thoughtful quizzes. I just have very quick comment for the last question about the impact of exercise. Now we have romosozumab to help with the bone formation. What does romosozumab do? It inhibits its monoclonal antibody against sclerostin. It's an expensive therapy, and it has concerns regarding cardiovascular risk. You can bring it down sclerostin just with weight-bearing exercise. If you exercise maybe around 30 minutes a day, you can bring the sclerostin down and you can improve the bone formation rate. And there is also benefit beyond the bone health. You improve your heart, the dyslipidemia, the diabetes, several other factors. So you can save your patient a lot of money and risk if you are successful to convince your patient that exercise improves the osteocyte function. Osteocyte dysfunction is a major risk of bone loss. So, and we know that sclerostin comes out from the osteocytes. It's not only sclerostin, but FGF23, a lot of cytokines, activin A, rank L, several other hormones, and co-players in the bone health comes out from osteocyte. So if you convince and if you counsel your patients to do weight-bearing exercise regularly, you can improve the osteocyte function, you can improve the bone health, you can decrease the sclerostin level, and beyond. So I'm really happy that you brought this up for our last take-home message. Natural intervention, non-pharmacological intervention,
Yes.
they are usually cheaper and safer. So as a physician, we know how to prescribe medications, but before prescribing medication, we need to talk about non-pharmacological interventions, which are very, very pivotal and essential for our patients.
Yes. Thank you, Dr. Am.
Thank you so much, Sally. Dr. Bassel, we are concluding our meeting today. So Dr. Bassel, Dr. Ehab, Dr. Amani, Dr. Yaoud, if any of you have any final comments before we close our meeting tonight.
Yes, can I? Sorry, can I? Do you hear me?
Yes, we do.
Yes, sure. Just I endorse what you have said about exercise. I have experience with young patient coming for screening for osteoporosis. Many they do osteoporosis before menopause, and they have low bone mass. Considered as low bone mass for using this score. Pre-menopause we use this score. And just I have experience, and just I did a short study in my patient, 10 patient pre-menopause with exercise after 3 years. They even get more bone, which means exercise can really help. We shouldn't neglect this aspect of treatment, and relatively costless, because some should go to the gym and they should pay the gym, but they can do exercise at home. We give them some videos how to do the exercise at home. And at the end, I need to thank you for inviting me to this webinar, interesting webinar with the distinguished speakers, and really I'm proud to be your guest. Thank you so much.
Thank you so much, Dr. Bassel. Your attendance and contribution today is highly appreciated. We are very glad, very happy to have you with us.
Thank you.
Dr. Amani, Dr. Yaoud, Dr. Ehab Turabi, do you want to say final words?
Thank you, Dr. Amr, for your elegant meeting, this elegant meeting. I would like to say the use of steroids is mandatory in our daily practice, but use the less dose, use steroid with lesser systemic effects, use steroid for shorter period and taper to the lowest dose. Pulse steroid is now preferred to use not more than 5 milligram. It will give the good results we need with little side effects. Steroid-induced osteoporosis is seen in our daily practice, sometimes reach to a vascular necrosis, sometimes reach to great disability to the patient. Use the lowest dose, and within 2 months we should taper the dose of steroid to less than 10 milligram if we can. Thank you very much.
Thank you, Dr. Ehab.
Thank you,
Thank you.
Dr. Am. Thank you, Dr.
I have a
Bassel.
Dr. Rahimani.
Yes.
I have a
Yes.
comment. The call-host, Dr. Ehab. Dr. Ehab, do you have experience about the use of alternative day therapy for steroid in patients with lupus or rheumatoid arthritis? There is recommendation in some endocrine review about to minimize the side effect, especially osteoporosis of steroid users. Use of alternative day therapy. If your patient on 10 milligram prednisone, for example, and the use of 20 milligram prednisone day after day, there is this minimize the side effect of
I
steroid.
think, Dr. Muhammad, it is a cumulative dose rather than a dose day after day. A cumulative dose is important in steroids. The type of steroid, it is genomic or non-genomic effect is important. I think alternate day is important for lesser hypothalamic pituitary axis affection, but in our daily practice, it is it does not decrease the osteoporosis, especially in patient with lupus who take higher doses, even if they take it day after day. We use day after day sometimes because we have not in Egypt less than 5 milligram tablet. I think outside Egypt there is 1 milligram methylprednisone tablet, and this is gives the opportunity for decreasing the dose very gradual, and we can use only 1 or 2 milligram. So alternate day may be useful for reducing the dose rather than reducing osteoporosis.
Yeah, thank you, Dr.
Thank you, Dr. Muhammad.
Amani, do you have any comments?
No, I just want to say that one of our priorities is to raise the awareness among physicians, not only patients, but only during the preventive measures to decrease osteoporosis, because most of specialties have high-risk patients, and they need to know that the patient must be screened like dermatologist, which they use large dose of steroid, gynecologist, face patients with infertility and ovarian failure, for example, and so. We start doing this by raising the awareness among physicians in the governmental hospital, in health insurance hospital, and so. Thank you, Dr.
Thank you. That's really an amazing meeting. And I'm going to close the meeting. I really appreciate all the attendants, presence today, speakers, moderators, and especially Dr. Bassel Masri with us today. Dr. Mamdouhi shared a link for the feedback, so please feel free to send us your feedback. It helps us to improve our performance for the future, for the next meetings. There will be certificates. If you like to get a certificates of attendance for the webinar, we'll be happy to send you certificates. We'll have this multidisciplinary meeting every 3 to 4 months. So please stay tuned for the next meeting, probably by the end of this year. I really appreciate everyone's contribution. Osteoporosis should be treated in a multidisciplinary team because it's a disease that has a devastating consequences, and it doesn't really belong to one specialty. I love to see in this meeting the diversity and the crosstalks between endocrinology, rheumatology, geriatrics, and nephrology. This is the way that we need to go and to move. We should have, conversation and dialogue rather than a monologue, because by the end of the day, we need to get the best benefit, and we don't want to introduce or to induce any harm to our. Thank you so much, and we'll see you in the next webinar. Have a good night.
ان شاء الله. شكرا.
شكرا.